All right, guys. Not able to see. Audible? Audible, guys. Yeah. Good evening. Good evening. Good to go. Audio okay? Okay. Clear? Visible? All good? All right. Good to go. Yes. Just answer yes, no. Good to go. Okay, guys. Okay. Okay. Right. So a quick recap from where we have left. I've kept the same slide where we have stopped yesterday. Uh, I'll just quickly go through what we went across yesterday. So we went across all the phases of goiter formation, right? So I spoke about the natural history of goiter. In the natural history of goiter, it all starts with iodine deficiency. We all can agree that the primary problem is the iodine deficiency, right? Now, that iodine deficiency was causing the negative feedback to convert back into positive feedback. All right. So the positive feedback caused increased in thyrotropin regulating hormone, which in turn increased the thyroid stimulating hormone, and that increase in thyroid stimulating hormone caused a positive growth factor causing diffuse hyperplastic goiter. Okay. Important points about diffuse hyperplastic goiter: they all have active follicles, they all have uniform stimulation. It is a reversible state. You start the patient on levothyroxine or iodine rich diet, the patient reverts back. Now, if the patient continues to ignore, there will be a fluctuating stimulus. Why I explained you how there is going to be a fluctuating stimulus. Due to the fluctuating stimulus, you will have the areas of active nodules and the inactive nodules. I can say the passive nodules. Now, the inactive nodules will start secreting colloids. It will, because already the follicles secrete colloid, but this time the special thing about it, there will be no iodine and there will be no hormone. So hence it is called as the colloid filled nodule. As the colloid filled nodule will increase in size, it will result in a colloid goiter. If patient continues to ignore, the active follicles will continue to grow. As the active follicles will continue to grow, there will be hyperplasia along with neovascularization. Now, because of neovascular tissue, which is highly friable, there is a good chance that it can break open. Now, as it will break open, it will result in bleeding, resulting in hemorrhage, right? Now, that hemorrhage will start exerting pressure, will push all the follicles to the periphery. And when the follicles are pushed to the periphery, we call it as the rind of active follicles, nothing but a rim of active follicles in the periphery of the nodule. Now, this hemorrhage, which has settled in the center, is going to exert pressure, and it will result in pressure induced necrosis and hence causing a central necrotic core. Now, it so happens, now the nodules are formed. Now, how does the nodule continue to grow? What happens is all these necrotic nodules, which are by each other, are going to coalesce together to form a bigger nodule. Hence, when this process occurs on repeated basis, it is called as multinodular goiter. It is called as multinodular goiter. So this is the natural course, how a normal gland is going to convert into a diffuse hyperplastic goiter, then to a colloid variant, plus minus into a multinodular goiter, into a multinodular goiter. I hope everybody understood until this point. Everybody got until this point? Good to go? Good to go? Good to go? But a dose of radioactive iodine will talk. Okay? Okay. Okay. But it is not hanging from my end. I also have the access to the eMedicos app. For me, it's running fine. But a dose of radioactive iodine I've spoken yesterday. For Graves' disease, I'll tell you in specificity, right? Just hold on to it. Now, with respect to the goiter, as I told you yesterday, goiter is nothing but enlargement of the thyroid gland. There could be multiple reasons. It could be because of I can say iodine deficiency. It can be because of toxic conditions. It can be because of neoplasia. Now, the WHO has given 3 grades to identify the significance. Grade 0 is non-visible, non-palpable goiter. So, it is subclinical goiter which is under development. Non-visible but palpable goiter. So initially when the gland enlarges, it has to be at least double the size to get palpable, or more than double the size, and it should be at least triple the size to be seen visible. It's a gross rule that we follow clinically, not authenticated but taken in that context, right? So grade 1 is non-visible but palpable. Grade 2 is visible as well as palpable goiter, right? Now, taking that into consideration, I spoke about the clinical features. I told you all thyroid issues are more common in females when compared to males because the thyroid follicles have estrogen receptors. So they actually respond, or thyroid tissue has estrogen receptors. So they respond to estrogen fluctuations. Now, male to female ratio is pretty high, 10:1. The swelling, which is usually present in the midline, moves with deglutination. These 2 points tell me that it is a thyroid associated anomaly. Now it is non-tender, it is smooth, it is smooth if it is diffuse hyperplastic, it will be nodular if it is multinodular. Obviously it will be firm. It is going to be firm. But a grade 0 is subclinical, it has to be diagnosed on an ultrasound only. Now we really don't get patients with grade 0, it is just a classification that is made, because if patient is not able to see, patient is not able to feel, he won't come to the OPD, no. But just see, in many countries we have something called as thyroid screening programs, especially in South Asian countries where the incidence of papillary cancer thyroid is more. So the young generation of the population where the papillary is more prevalent, or the family history with more prevalent disorders, they undergo screening. In that they found that the ultrasound was able to show increase in size which was neither palpable nor visible. So hence it is called as grade 0. Alright. Beta dominant nodules and all will talk. Okay, we are in the process. So clinical features: swelling in the midline of the neck, moves with deglutination, non-tender, smooth if it is diffuse, nodular if it is going to be multinodular. It is going to be firm. There will be gradual increase in size. I told you one pitfall to remember. Agar there is sudden increase in size, there could be 2 reasons. Either it is a hemorrhage or a malignant transformation. One of the important clinical pickup point is hemorrhage is usually associated with pain. Malignant transformation is usually painless. It is usually painless, right? With respect to long-standing goiter, as the gland is going to enlarge, it is going to compress the trachea, right? Along with the compression, if it enlarges from one end, it is going to push the trachea to the other side, to the contralateral side. So there will be lateral thinning of the trachea, which can be seen on an X-ray, and this is called as Skarbart trachea. Skarbart is nothing but that knife that I've shown you yesterday. No, that is called as Skarbart, right? So Skarbart trachea is demonstrated. I can say the Caucus test is done when you push the lobe from one end and you ask the patient to inspire, and he'll produce stridor because the trachea compression will further aggravate, right? Now that is called as Caucus test positive. Skarbart trachea is an X-ray finding. Skarbart trachea is an X-ray finding. That is one thing that you need to keep in mind. Alright. But a Caucus test is done by asking the patient to sit on a round stool. You will compress the lobe from one side. If let's say you want the majority of the portion which is enlarged on the right lobe, let's say you push the right lobe a bit more, from lateral to medial side, and the trachea will get compressed. On compression, you'll ask the patient to inspire and it will produce stridor. And presence of stridor during inspiration is a positive Caucus test. It's a positive Caucus test. Okay. Okay. But a simple goiter itself means euthyroid state. Okay, that is why we call it a simple goiter. Toxic ka matlab hota hai hyperthyroid state. So all of these will have euthyroid status. Okay. Now let's continue the discussion from here where we left yesterday. We'll talk about the See, the patients can come with two scenarios. One, a normal patient which we have discussed without any complications, and patients who come more late. They wait for long. They want them to, suffer more. They don't want to have medical attention right away when they feel something is abnormal. They want to see how extensive the body can bear, how long can the body can stay on it. So these are the patients who are special to us. They are the one who are challenging as well, but we learn a lot from them. So I'm going to talk about complication of multinodular goiter. So we're going to talk about multinodular goiter, the complications associated with multinodular goiter. One of the complication is, if a patient has multinodular goiter and he still does not seek any medical attention, a few years later down the line, these nodules which are formed, they have the tendency to have an autonomic change. We'll discuss about it. And because of that autonomic change, they will result in secondary thyrotoxicosis. They will result in secondary thyrotoxicosis. In fact, as much as 30% of the patients with multinodular goiter will land up with secondary thyrotoxicosis. Now, what do you mean by secondary thyrotoxicosis? Thyrotoxicosis, thyro is thyrotoxic, means increase in state. So there will be increase in level of T3 and T4, causing hyperthyroid state, resulting in hyperthyroid state. Secondary to what? Secondary to what is the question? Secondary to pre-existing swelling. Secondary to pre-existing goiter. Now, a secondary thyrotoxicosis is a condition which is going to happen in a pre-existing goiter converting into a toxic goiter. Hence the name is given as secondary thyrotoxicosis. Remember, it is not a rare entity. As much or as high as 30% of the patients usually land up getting into secondary thyrotoxicosis. Another very important and a dreadful condition that we all should be aware of, long-standing goiter is a risk factor for follicular cancer thyroid. Long-standing goiter is a risk factor for follicular cancer thyroid. Around 10% of the patients with multinodular goiter on long-standing basis may land up with follicular cancer thyroid. May land up with follicular cancer thyroid. Along with that, I already told you that is hemorrhage, and this hemorrhage is going to be associated with pain. So patient is going to have pain along with hemorrhage. Now, as the size of the gland is going to increase, it is going to compress the trachea, which is going to result in tracheal compression. This tracheal compression is going to cause difficulty in breathing. This is going to result in difficulty in breathing. So tracheal compression is an associative complication. Beta, how does the hormone level increases? That change in secondary thyrotoxicosis we'll talk about when we talk about toxic goitis. Okay? So that is a discussion there. So we'll try to concentrate on what we have in our hand right now. Another one, it can also, see, if a multinodular goiter, which was initially firm to feel, has converted into hard in texture. So let's say you had a patient who had a multinodular goiter and he has been there for follow-up with you, and you felt initially the nodule was firm and later on it turned into hard. For reference point, I would like to tell you soft, firm and hard are the three consistencies that we usually address for the swellings. Soft, you can press against your lips, and this is the consistency of a soft swelling. Firm is your tip of your nose, that is your cartilaginous part. This is how the firm will look like. And hard, you can press across your forehead and you'll be able to see the same persistence as they're going to be there in hard texture. So if a multinodular goiter, which was initially firm, has later converted into hard, this hardness is usually secondary to calcification. This hardness is usually secondary to calcification. This hardness is associated or it is usually secondary to calcification. Remember, the pattern of calcification in a multinodular goiter or a benign condition is going to be coarse. It is going to be coarse. So when you do an ultrasound, in the periphery you will see a rim, a thickened rim of calcification. So it won't be like, specules or small dots. There'll be a full rim of calcification, and such calcification are called as coarse calcification. If you ever come across fine calcification, specifically in thyroid, which is also referred to as microcalcification. Now, in order to label them as microcalcification, the size of the calcification should be less than 0.5 millimeters. Now, if you ever come across microcalcification on an ultrasound with respect to a thyroid gland, it usually points towards papillary carcinoma. It usually points towards papillary cancer thyroid. It usually points towards papillary cancer thyroid. A very important radiological point which Sumer sir will also stress upon, that these microcalcifications on an ultrasound will not have, or will there be absence of post echogenic shadow. Sorry, there will be presence of, or no, correct, there will be absence of post echogenic shadow. So there will be no shadows after the specules are noted. That's very important. So root is thyroid hormone status is multi. But until it is called as simple multinodular goiter, the status is going to be euthyroid. If it is toxic multinodular goiter, the status is going to be hyperthyroid, right? If the gland is damaged, as more amount of nodules are going to get calcified within a very long period of time, as the lobules are going to get calcified, they'll get fibrous, then the patient may turn into hypothyroid, right? But usually the multinodular goiters, if they're simple, they'll present with euthyroid state. If they're toxic, they'll present with hyperthyroid state. So coming back to the complications, number one is secondary thyrotoxicosis, follicular carcinoma, hemorrhage, tracheal compression, getting into a calcified nodule or a hard nodule are the existing complications. And these are the complications which are associated with multinodular goiter. Right? Now talking about the indications for surgery in the patient of goiter. What are the indications for surgery in a patient of multinodular goiter? Calcification. Okay, but see, when you see calcification on an ultrasound, if you see a rim of calcification, like it's a continuous thick band of calcification, this thick band of calcification is called or known as coarse calcification, right? They're called as the coarse calcification. On the other hand, if you see the calcifications which are present like fine specules, these are referred to as microcalcification. Okay, those who are asking for post-echogenic shadows, one second, I'll show you that as well. In papillary cancer, you will have microcalcification. These microcalcifications in papillary cancer is also referred to as Samoma bodies. We'll discuss about them when we talk about cancers. These are also called as Samoma bodies, which indicates presence of dystrophic calcification. Now, I emphasized by saying that the microcalcifications of papillary cancer thyroid will not have post-echogenic shadows, right? Now, I'll show you an image to be on the safer side. Just give me 1 second. Okay, guys, 1 second. Okay, now look at here in this image. This is an ultrasound image. Okay. Now, if you are able to follow with me, I'm just going to mark them. This is the area where we're looking at, and these bright spots, right, between these arrows, you can see the brighter spots. Here one, see here one, sorry, this one, this one, this one, right? So these are the calcification that you are able to see. Got it? Are you able to see? Able to follow? But it's a pathological change, no? The presence of dystrophic calcification. It's a finding that we have. Why would that happen is a different story. But then, right, okay. Now, what I'm trying to explain here is, you see, after the calcification is denser. So after the calcification, there should be an echogenic shadow which should be present here, right? Usually it is present. It is absent in papillary cancer thyroid. Post-echogenic shadow is going to be absent in papillary cancer thyroid. Okay. Now, because see how small the calcifications are, they're very tiny calcifications. They're less than 0.5 millimeters in size. Hence, they are called as microcalcification. All right. Because the why post-echogenic shadows are missing, because the calcification is so tiny that the sound waves will pass through it. देखिए echo कब बनता है? When the density is more and the object is wider, so that the sound can hit and come back. The calcification is so tiny that the sound will pass through it. It is enough to mark as calcification, but it is not good enough to reflect the sound back, right? So hence you will not have a post-echogenic shadow. More technical reasons, I think Sumesh sir will answer on this. But this is what I wanted to show. Another image. Another image that I want to share with you guys is this one. You able to see, everybody? All right, good to go. Not able to get response. Okay. Now, if you look at this image, look at this calcification, and after the calcification, you have this post-echogenic shadows. You see right across here. These are the post-echogenic shadows. These are the post-echogenic shadows, right? The shadows are present, right? If you have post-echogenic shadow, everybody is able to look through. You see the shadow is falling through, right? Now, if this is present, we cannot call it as papillary cancer thyroid. That is what I'm trying to explain you. The difference between these two, if you have papillary cancer thyroid, look at the image now. There is no evidence of post-echogenic shadow. You see, you concentrate here, there is no post-echogenic shadow. On the other hand, when you look at the benign condition, which is also associated with calcification, you will have post-echogenic shadow. You will have post-echogenic shadow, right? So, based upon ultrasound, how do you differentiate? You differentiate if there is absence of post-echogenic shadow, it indicates papillary cancer thyroid. If you have presence of post-echogenic shadow, it is benign nodule. It is going to be a benign nodule. Got it? Right? Good to go? Okay. So these are the complications, right? So we'll talk about indications for surgery. Indications for surgery in a patient of multinodular goiter, or I can say in terms of goiter, per se, generalized indication for surgery in patient of goiter. Number one, if the patient has or continues to increase in size, or the gland size continues to increase even after receiving T4 supplementation, even after getting T4 supplementation. Okay, now why, in which patient will give T4 supplementation? I already told you, we give in a patient of diffuse hyperplastic goiter, which is a reversible state. We start the patient on iodine supplementation and thyroxine. If patient does not respond, that means if it continues to grow in size even after receiving T4 supplementation, that is the first indication for surgery. Following that, if patient has any form of obstructive symptom, if patient have any form of obstructive symptoms. Now, when I talk about obstructive symptoms, I mean following things. Number one, as the gland enlarges, it is going to push the trachea, so patient is going to have dyspnea. That compression will be transmitted onto the esophagus, which is going to result in dysphagia. If patient develops stridor on lying down, these indicate that the patient has obstructive symptoms. These indicates patient has obstructive symptoms. Right, so dyspnea, dysphagia and stridor indicates obstructive symptoms. Obstructive symptoms. At any point, if you think or feel or suspicious of malignancy, if you are suspicious of malignancy, you should go ahead with surgery. Another one, if patient has multinodular goiter. Multinodular goiter itself is an indication for surgery. Last but not the least, that is cosmetic. If a young lady comes and says it doesn't look nice, she wants to show her neckline properly, you cannot argue with the patient. It's the patient's neck, patient's choice. She wants to get it rid of, you should be able to do that, right? So no argument with ladies. So just hands down and say, okay, we'll go for it. Okay, so that is with respect to indications of surgery. All right. Now, talking about management, how would you like to deal the patient of goiter? All patients where the indication of surgery is there, we'll go with surgery, and the surgery of choice happens to be total thyroidectomy. The surgery of choice in all patients of goiter is going to be total thyroidectomy with lifelong supplementation of thyroxine. With lifelong supplementation of thyroxine, right? This is the surgery of choice. Now, things become peculiar, because your examiners want to ask questions which is more clinical based, right? So what scenario they can change, they can ask you with relate to age, right? If you have a patient of a goiter who is apt for surgery and the patient is young, what will be the surgery of choice? The surgery of choice or the treatment of choice is going to be total thyroidectomy. On the other hand, if you have an elderly patient, now elderly patients are usually, they're more or less associated with one or two comorbidities. There'll be contraindication for surgery, or they may not be able to tolerate surgery well. In those patients, now the thing becomes tricky. Right? Why it is tricky is you have to go for surgery, but judicial surgery is what they excise. They say whichever lobe is involved, let's say this is the gland, let's say both the glands are involved, but the right side is involved more when compared to left side. The entire gland is enlarged, but right lobe is enlarged more than when compared to left lobe. Right lobe is enlarged when compared to left lobe. Now, in those patients who have this issue, we are going to remove the side which is affected. more. We are going to remove the side which is affected more. Remember, we only remove the lobe, not the isthmus, and this is now called as total lobectomy. In total lobectomy, only lobe is removed. Isthmus is spared. Isthmus is spared. Now, what would you like to do for the contralateral side? Now, the side which is less affected, the side which is, you can say, not affected, either less affected or not affected, what would you like to do? So I have two scenarios. One, it is less affected. Another one is normal. There could be two possibilities. The other lobe is either less affected or normal. If it is less affected, I would like to go for either a subtotal lobectomy or a Dunhill surgery. Both are acceptable. If it is normal, no intervention is required. If it is normal, no intervention is required. But don't get confused. We'll talk about thyroid surgeries in detail. When we say total lobectomy, only the lobe is removed. We are not going to remove the isthmus, right? When I say subtotal of a lobectomy, in that, if this is the lobe, on the superior or the inferior pole, you are going to leave 4 to 5 grams of the tissue, and the rest of the gland is going to be removed, right? This is called as subtotal. We'll talk about them in detail again, just for the references I'm trying. In Dunhill procedure, if this is the lobe, on the periphery we'll leave a thin rim of tissue, and rest of the thyroid lobe is removed. This is called as Dunhill. This is around 8 to 10 grams is going to be left behind. 8 to 10 grams is going to be left behind, and this is called as the Dunhill procedure, right? I hope the protocol is clear. This is where they get you, make you a bit difficult and think you more, ask you to interpret it more. So if they say, I'll make it very clear. If they say, what is the surgery of choice for simple multinodular goiter? The answer is total thyroidectomy with lifelong thyroxine. On the other hand, if they say a 78 years old female patient with multinodular goiter, what is your management? Then they will tell you if right lobe is involved more or left lobe is involved more. If whichever lobe is involved more, that has to go completely. So you'll go total lobectomy. Contralateral lobe, you will see whether it is affected or not affected. If it is normal, there is no intervention required. If it is going to be affected, I will go either with subtotal or Dunhill surgery. I'll go with subtotal or Dunhill surgery. Good to go. Any added advantage? One of the added advantages, see, in young patients we go for total thyroidectomy because we don't want them to have recurrences, because repeat surgery is going to be very difficult, because you would have distorted all the natural planes. It will have become a lot of adhesions, there will be a lot of neovascularization, so re-exploration is going to be very tricky and costly for the patient. So if the patient is young, we go for complete thyroidectomy. In elderly patients, you see, recurrence occurs around 8 to 10 years or 5 to 10 years after. So it is not immediate recurrence that we are looking at. Whereas in the patients who are elderly, one, I want the endogenous hormones to be present. Second, I'm not worried about recurrence in these patients, right? So whichever diseased, I'm trying to limit my surgery, because ligating both the superior thyroid artery, both the inferior thyroid artery, either side of the veins is going to be a longer procedure. So I'm not trying to cut down the morbidity of the surgery. So I'm trying to be lesser invasive. Okay. So if benign, why surgery? But it still costs, see, one, it can still transform into, so the question is, if it is benign, why still you want to do surgery? Now, it's been a very long debate. If it is benign, why do you want to surgery? I just told you one of the complications is thyrotoxicosis. It can convert into thyrotoxicosis, and it is 30%. More dreadful, it is going to be follicular cancer. And I told you long-standing goiter is a risk factor for malignancy. The longer you live, the more chances of getting malignancy is there. Okay. But 8 to 10 grams is preserved. This is preserved, rest of the gland is removed. Here 4 to 5 grams is preserved, the rest of the gland is removed. Okay. बेटा subtotal में on the pole, either on the superior pole or the inferior pole, depending upon the location of the disease. अगर disease inferior pole पे है, superior pole free है, तो you are going to save the superior pole. 4 to 5 grams of superior pole is left, rest of the lobe is removed. That is called as subtotal. ठीक है. Dunhill surgery, or it is also called as the Hartley-Dunhill surgery. In Dunhill surgery, in the periphery of the lobe, I will leave around 8 to 10 grams of the tissue and rest of the lobe will be removed. But lymph nodes, okay. See, lymph nodes are going to be evident with respect to malignancy. Agar malignancy hai hi nahi, to lymph node ka status hi nahi banta. Okay, so you don't need to worry about lymph nodes. Okay. Good to go. Good to go. Okay, right. So this is the management with respect to goiter. Now we'll take a special scenario in goiter. Within the goiter, we have a special type of goiter which is called as retrosternal goiter. It is called as the retrosternal goiter. If both lobes, but if the lobe, see again, the concept is simple. In elderly patients, I want to decrease the morbidity of the surgery, so I'm going to limit the excision. Agar both the lobes are extensively involved, then you have no choice other than go for total thyroidectomy. That is why I'm giving you scenarios. No, if you have two lobes and one lobe is involved more when compared to the other lobe, you remove this lobe and throw it. You think about the lobe which is left. Is it having nodules? Is it diseased or not diseased? If it is normal, you don't need to do anything. You come back. Leave there itself. If this lobe has nodules, you see whether it is present on the superior pole or is it present on the inferior pole. Let's say it is present on the superior pole. In the inferior pole, you leave a little bit of gland and rest of the lobe you remove. Vice versa, if the disease is present on the inferior lobe, you remove the entire inferior lobe, leave a bit of tissue that is 4 to 5 grams on superior lobe and be done with it. Let's say you have involvement of both superior lobe, inferior lobe, but the lateral part is spared. You remove both superior and inferior, only leave a small rim of tissue. The small rim of tissue you leave, and this is called as Dunhill procedure. Right? But don't worry about thyroid surgeries. I have given one day exclusively for thyroid surgeries. We'll talk about thyroid surgeries, type of surgeries, steps in surgeries, intraoperative complication, post-operative complication, management of complications, right? So we have designed the lecture, we have posted the schedule also, so we'll all stick to that, right? Okay. Now, let's get to the business part of the day today. We talk about retrosternal goiter. When I say retrosternal goiter, the definition itself, it says when more than 50% of the gland, is located below the neck level. When more than 50% of the gland is located below the neck level, we call it as retrosternal goiter. Beta thyroid surgery associated doubts. I'll do it day after tomorrow. If you are not comfortable with whatever I've taught you, then you can continue as doubts, right? For now, you forget about the surgery. You have written down subtotal, you have written down Dunhill. We'll talk about it. Okay. Now let's concentrate on retrosternal. It's a lot of concept that you need to digest here. Okay. Now in a retrosternal goiter, when I say 50% of the gland is below the neck level, we take the neck level reference point as suprasternal notch. The suprasternal notch is taken, STN is suprasternal notch. Suprasternal notch is taken as a referral point. Okay. Now, if more than 50% of the gland, when more than 50% of the gland is located below the neck level, if more than 50% of the gland is located below the neck level, it is called as retrosternal goiter. It is going as retrosternal goiter. Now, the other way of describing the retrosternal goiter, or an alternate definition that we have for retrosternal goiter, if the extending mass is reaching to the fourth thoracic vertebra. If the mass is reaching to the fourth thoracic vertebra, this is referred to as retrosternal goiter. So we have two standard definitions for retrosternal goiter. One, if more than 50% of the gland is located below the neck level, or the mass is reaching to the fourth thoracic vertebra. Either cases we call them as retrosternal goiter. Now, based upon the etiology of the retrosternal goiter, I can divide the retrosternal goiter into two types. This is based upon the etiology. Based upon the etiology, I can divide the retrosternal goiter into two types. One is called as the primary retrosternal goiter. Another one is called as the secondary retrosternal goiter. Primary, another one is secondary. Remember, secondary retrosternal goiter is far more common when compared to primary. Now, when do you call it as a primary retrosternal goiter? When you have an ectopic thyroid tissue, when you have an ectopic thyroid tissue in the intrathoracic region, or I can say in the retrosternal region, and that converts into or forms into a goiter. This is referred to as primary retrosternal goiter. It is referred to as primary retrosternal goiter. So it's congenitally you have an ectopic thyroid tissue which is present in the intrathoracic or in the retrosternal region, which has transformed into a goiter. Goiter is nothing but enlargement, and that is called as primary retrosternal goiter. Now, the secondary retrosternal goiter is an extension of enlarged neck goiter. It is an extension of enlarged neck goiter. Extension of an enlarged neck goiter, it is referred to as secondary goiter. It is called as the secondary goiter. Remember, the secondary retrosternal goiter is far more common when compared to the primary retrosternal goiter. Right. Now, based upon their presentation, they are divided into three types. Based upon the clinical presentation, the retrosternal goiters are divided into three types. Number one is called as the substernal goiter. Number two is referred to as the plunging goiter. And number three, it is referred to as intrathoracic, also called as retrosternal. Okay. Based upon the clinical presentation, we have substernal, plunging, and intrathoracic. Now, what do you mean by substernal goiter? In a patient of substernal goiter, you will be able to appreciate the swelling which is in the cervical region, but only the superior pole is appreciable. The rest of the gland is synced downwards. So a part of the swelling is visible in the neck, and the rest of the gland stays inside the thoracic region or below the neck level. This is called a substernal goiter. On the other hand, when we say plunging variety, in the plunging variety, the gland is usually not visible. The gland is usually not visible in the cervical region. It is completely intrathoracic. But when you increase the intrathoracic pressure, either by doing a Valsalva maneuver or you ask the patient to swallow, Because of the relative motion, the gland is going to move upwards, and you will be able to appreciate the superior pole. So in a plunging variety, in a resting position of neck, you will not be able to appreciate any swelling in the cervical region. But when the patient does a Valsalva maneuver, or when the patient takes heavy swallows or deep swallows, or you can say expulsive swallows, that will happen. The gland is going to move upwards. Now as the gland is going to move upward, the superior pole will be visible in the neck region, and such a variety is called as plunging variety. Such a variety is called as the plunging variety. On the other hand, when we talk about the intrathoracic variety usually does not present clinically because they do not present with any symptoms, because the gland remains intrathoracic only. The gland remains intrathoracic only, and it is never visible. It is never visible in the neck. Intrathoracic retrosternal goiter is a radiological diagnosis. It's a radiological diagnosis. Clinically, it is near difficult, I can say impossible, for suspecting it. Right? Understood all three varieties? Substernal variety, you have the swelling which is present or visible in the neck. When you ask the patient to swallow, it moves as well. Okay. In a plunging variety, resting position, there is no swelling, but when you increase the pressure in the thoracic region, or when you ask the patient to take a deep swallow, it is going to move upwards, right? Then you will be able to appreciate the superior pole. This is the plunging variety. It goes up and come down, goes up and come down. This is called as plunging. So something is plunging down back, right? Hence the name is plunging. Intrathoracic, it remains within the thoracic cavity. It does not shoot up back to neck, right? But I don't have any images for retrosternal goiter. But clinically, I can show you a large gland which is extending into the thoracic region, but then it is very difficult to differentiate. Plunging varieties is rare. Intrathoracic, as I told you, I have the surgery videos which I'll share later on. Okay. Right. Now, let it be anything. Because it is goiter, there will be an enlargement. As there will be enlargement, there will be symptoms. So how does a patient of retrosternal goiter present to us? So we're going to talk about the clinical presentation of patient with retrosternal goiter. One important thing with respect to all the varieties, see, all goiters are more common in females when compared to males. Even the retrosternal goiter is more common in females when compared to males. The only exception is the intrathoracic goiter, which is more common in males when compared to females. It is more common in males when compared to females. Okay. Now this is a very, very important point to be remembered. Alright. Good to go. Beta, substernal is a type of retrosternal goiter. There is no versus. वो दोनों एक दूसरे के लिए लड़ नहीं रहे. They are not fighting with each other. They are of the same tree. ठीक है. All three varieties, substernal, plunging, intrathoracic, all three are retrosternal goiters. These are the types of retrosternal goiters. Okay, so we talk about the clinical features which are associated with retrosternal goiter. Now, see, in the retrosternal point or retrosternal part, all that you have to understand, let's say this is the enlarged gland. Right next to it, you have the trachea. Behind the trachea, you have the esophagus, and behind the esophagus, you have the vertebral column, and in front, you have the bony sternum. Right? This is the orientation that you need to have. Now, once the retrosternal goiter is going to enlarge in size, it is going to compress the trachea. Now, as the trachea is going to get compressed, this compressive force is also going to be transmitted onto the esophagus, so there will be narrowing of the esophagus as well. So the symptoms will be pertaining with respect to esophagus as well as trachea. Why intrathoracic more in male? Beta, even I don't know it. It is probably the finding, or I can say with respect to the incidences that we found, that it is more common in males, right? Some things you have to accept. There are no reasons. No, some things is like facts. Facts is facts. So you remember them, right? Clinical presentation. Now, when the trachea is going to get compressed, it is going to be, or patient is going to have dyspnea. A characteristic point about this dyspnea is when the patient is sitting up or walking or working, it does not cause much of an interference. But when the patient lies down, this is going to compress back onto the trachea. Hence, the dyspnea which is present increases on lying down. Increases on lying down. It's a very, very important pickup point. So remember across it. Okay. But whichever I write Q, that is an MCQ. I mention it if it is an important point, and if it's a previous exam question, I'll mark it with a Q on top. Okay. So for example, just now I did. Every time changing color is difficult, no? So just follow that link. So tracheal compression is going to cause dyspnea, which is also going to result in cough. Chronic compression is going to cause softening of the trachea or flabby trachea, which is going to result in stridor. As the esophagus is going to get compressed, the patient is also going to present with dysphagia. Now, as the gland enlarges, it is sitting right across here. So this is your suprasternal notch. This is your clavicle, which is present right across here. This is the first rib, right? Now, as the gland enlarges, it is going to obliterate this space. There you have your thoracic inlet as well. Now, as the thoracic inlet is going to get compressed, patient is going to have distended neck veins as well as distended superficial chest veins. Distended superficial chest veins. Basically, it is obstructing for draining into superior vena cava. Right? So, patient is going to have dyspnea. Patient is going to have cough. Patient is going to have stridor, that is because of flabby trachea, dysphagia because of compression of the esophagus, distended neck veins and superficial chest veins because of obstruction to thoracic inlet. Because of obstruction to the thoracic inlet, right? Along with that, a classical sign that you will see with respect to retrosternal goiter is presence of Pemberton sign. Now, Pemberton sign is nothing but you ask the patient to elevate the arm. Ask the patient to elevate the arm above the head. Ask the patient to elevate the arm above the head and to take deep inspiration. And after a while, you will see presence of facial congestion. Presence of facial congestion, as elevating the arm will further obliterate the thoracic inlet, hence causing the same problem, right? So the vascularity will get further compromised, so hence the congestion will occur. So Pemberton sign, on elevating the arm above the head, ask the patient to take a deep breath and you will notice presence of facial congestion. Presence of facial congestion while doing this is called as positive Pemberton sign. Called as the positive Pemberton sign, and this has been your previous exam question. Okay. Positive Pemberton sign. Another clinical pickup point that you can get from here is on percussion. On percussion, it will be dull node on sternum. Normally we expect resonance on the thoracic cavity, but presence of dull node indicates extension of the gland. But not flushing, it is congestion. The veins will not be able to open. No, the neck veins are going to drain into your superficial, that is your SVC, while when you elevate the arm, you further obliterate or narrow your thoracic inlet. So the draining will further hamper, so there will be more pooling of blood. As more pooling of blood will be there on the face, you will have congestion, right? The presence of facial congestion. But I just told you, no, it is going to obliterate the thoracic inlet. The thoracic inlet is a space which is present between the clavicle, the first rib, the two muscles, the anterior scalene muscle and the middle scalene muscle. Between this box, between clavicle, first rib, anterior scalene and middle scalene is your thoracic inlet, from where you have your subclavian vessels and your brachial plexus go through, right? But it will be dull. No, the gland is here. So when you percuss on the thoracic cavity, because lungs have air, you are supposed to get resonance. But rather than getting resonance, you'll get a dull note. You'll get a dull note. Okay. But it is node. I've written node. Okay. Okay. Right. So this is the presentation of a patient with retrosternal goiter. So retrosternal goiter patient is going to present with dyspnea, cough, stridor, dysphagia, distended neck veins, distended superficial chest vein because of obstruction to thoracic inlet, positive Pemberton sign which is characteristic, and percussion, it will be dull. Okay. Now, once you have a patient of suspected to be a retrosternal goiter, how would you like to investigate this patient? Now, each patient will come with different scenarios. Let's say if you have a substernal goiter, you will see a visible neck swelling. So it makes sense that you want to evaluate him. Plunging variety also, you will have a visible neck swelling. Whereas in an intrathoracic patient, it will be purely inside, only presence with pressure symptom, that is cough, stridor, dyspnea and dysphagia. That is at all. Okay. Now, how would you like to investigate? The first investigation is always an ultrasound. Right? So ultrasound will be able to tell you the extent of the gland. The best investigation to confirm the diagnosis would be a radioactive iodine scan. Iodine 123 is preferred over technetium 99 pertechnate scan. In fact, why radioactive iodine is the investigation of choice? It not only tells you that there is a large gland that is present, it also rules out the other mediastinal tumors. It also rules out the other mediastinal. Tumors. Ultrasound will tell you there is a mass, but ultrasound will not be able to tell you whether it's a thyroid mass or a mediastinal mass or a thymic mass. Whereas the radioactive iodine will tell you it is a mass, it is a thyroid mass, because thyroid mass will have active uptake or exclusive uptake of iodine. So it also helps out to rule out. Other medical or other mediastinal tumors. Now, if you are planning for surgery, CT, neck and chest is important. CT, neck and chest is important. Okay. Now here comes a tricky question. What CT would you like to use? A contrast CT or a non-contrast? A contrast CT or a non-contrast CT? A contrast CT or a non-contrast CT? Contrast CT or a non-contrast CT? But then face to face, I'm just coming to the same discussion. No? CT pe hai abhi hum log. Okay, how many of you say contrast CT? And how many of you say non-contrast CT? Okay, majority of you are thinking about contrast CT. Now here's the problem. Let's say you want to do a contrast CT and you have removed the gland and you found out there are malignant changes. Right? Now, if you have malignant changes in that gland, what is the post-operative management? Once you have removed the gland after surgery, logically you want to give radioactive iodine. Now the problem is, in a contrast CT, the contrast that you give are the iodinated contrast. They are the iodinated contrast. Problem with the iodinated contrast, it will interfere with radioactive iodine. So that is why whenever you have any suspicion or it points towards malignancy, you should always avoid contrast CT. In fact, contrast CT is contraindicated for thyroid malignancies or suspicious of thyroid malignancies. You should always prefer non-contrast CT. You should always prefer a non-contrast CT. A very, very important point. I repeat again the reason. If you give a contrast CT, the contrast agent that you use is an iodinated contrast, and that iodinated contrast will interfere with radioactive iodine, because the same the same thyroid tissue will be competing for the iodine from the contrast as well as the radioactive iodine. If the tissue is already loaded with iodine which you have given in the contrast, the radioactive iodine will not be taken. Hence, there will be no ablative effect. So that is why all suspicious cases, any thyroid malignancy, you're trying to work it out, because CT is indicated only in thyroid malignancies. Now, if you're talking about in terms of thyroid, so we're talking about thyroid malignancy, you're trying to work it up. Contrast CT is contraindicated. Just keep that in mind, and this is a very, very important point. So contrast CT is contraindicated for the workup of thyroid malignancy, or even if you have suspicion of thyroid malignancy, you should go for non-contrast CT. Non-iodinated contrasts can be done, but then we normally urographin, whatever contrast that we use, is usually iodinated. Because you will see, until unless you're not suspecting it to be that contrast, you will not instruct that. No, so it's better to be safe than sorry. Beta contrast, non-contrast, Sumer sir will tell you. No, आराम से बताएंगे, not an issue. ठीक है? They'll tell you in fursat. Abhi clear? This is the point that you remember. Everybody is clear with this, because this is a very important root point, right? Beta technetium can be used. Technetium can be used, but then because it is not specific, technetium is still under process. Once it gets better, we'll move towards technetium, because same day imaging can be done. But it's true for all the malignancies, all thyroid malignancies. I'm not talking about other malignancies. I'm talking about thyroid malignancies, because thyroid tissue compete for iodine. I told you the reason also. अगर कोई thyroid tissue बच गया, malignant tissue is left over, right? What will happen when you give a contrast agent which is iodinated? That malignant thyroid tissue will take that iodine and it will be filled with, or it will be loaded with that iodine. Now, when you give a radioactive iodine, the tissue is already full, or pura khana kha rakha is already eaten. So the new radioactive iodine that you have given, that will not be taken up. So it will be of no use, right? Good to go? Okay. So investigation, or the first investigation is ultrasound. Investigation of choice to confirm the diagnosis is going to be iodine 123. Investigation of choice to plan for surgery. Investigation of choice to plan for surgery, it is going to be CT neck. Remember, it should be a non-contrast CT neck. It should be a non-contrast CT neck. Alright? Okay. Surgery, it is total thyroidectomy. It is total thyroidectomy. The debate point is, where would be your incision? If you have a retrosternal goiter, where would you like to put the incision? Would you like to put the incision in the neck? Would you like to continue would you like to explore from the mediastinal part? How many of you say will go with cervical incision, and how many of you say will do a median sternostomy and go? Okay. The incision of choice. If the question says, what is the incision of choice for retrosternal goiter? What is the incision of choice for retrosternal goiter? The answer is going to be the cervical incision. It is going to be a cervical incision. If they specifically ask you the incision of choice for intrathoracic goiter, the incision of choice for intrathoracic goiter, intrathoracic goiter never comes into cervical region, so you will not be able to go through it. So in order to address the intrathoracic goiter, the incision of choice is going to be the medial sternostomy. Now the question is, the medial sternostomy that you're doing, what is the extent? Until where would you like to do it? Remember, we do it until the third intercostal space. This is the first rib, let's say this is the second rib, this is the third rib, and this is the fourth rib. So 1, 2, 3, 4. So third intercostal space. And then you can go for lateral extension. If the gland is more towards the right side, you go for the right lateral extension, or you go for the left lateral extension. So wherever. So between the third intercostal space, right? So the extent of the medial sternostomy. So if it is intrathoracic goiter, then you have to go for median sternostomy. The extent of the medial sternostomy is on the third intercostal space. You can go for lateral extension. I hope everybody is clear. There is no confusion. If they ask you what is the incision of choice for retrosternal goiter, the answer is cervical incision. There is no doubt at all. Now, if they ask you specifically for intrathoracic goiter, the answer is going to be median sternostomy. In the median sternostomy, I'm going to open the sternum all the way from the suprasternal notch to the third intercostal space. Now, after you have done that, the lateral extent should always be between the third intercostal space, right? Also called as a reverse T incision. Third intercostal space, ICS is intercostal space. Alright, good to go. Everybody's clear? But also, this incision is also called as a reverse T incision or an inverse T incision. Also called as an inverse T incision. Okay, right? Okay, good to go. Right, we'll take up the next topic. So until now, we have covered simple goiter. So you all now know about simple goiters. You know about the diffuse enlargement of the gland. When I say diffuse, that means the entire gland is generalizedly enlarged. So I'm going to talk about the next topic, that is going to be a localized thyroid enlargement, or also called as discrete thyroid swellings. Discrete thyroid swelling. Discrete thyroid, what is the most common presentations? But a most common presentation of a retrosternal goiter is going to be pressure symptoms, right? That is why the patient will have dyspnea on lying down, there will be stridor, that is on sleeping. Patient might have dysphagia, which is a bit later, but usually presents with compressive symptoms. Beta, if they say retrosternal goiter, let it be substernal, let it be plunging, you will go explore with cervical incision. But as a clinical scenario, I would like to tell you, any patient of retrosternal goiter, we keep the chest prepared. Just in case intraoperatively, if I want to go and explore through a median sternostomy, there should not be any issue at all. Okay. Why third intercostal? But that's the maximum extent where you need to explore. So third intercostal space is the lateral margin that you take across, or the most extensive margin. Okay. Itsy bitsy doubts. No. Guys, I'm not able to clear all the doubts in the running session because it is hampering the flow. And at the end, you guys are only saying, sir, why is it slow? Why is it slow? Right? So I don't want to slow down. I don't want to cut down the pace as well. Okay. So guys, let's continue. We'll make a ground rule from today. Until 9:30, there will be no interruption. From 9:30 to 9:45, I will keep for doubts. Whoever is interested, I will sit here for 10. Okay. You can ask your questions in the chat box. I will explain you exclusively. Done with that? Everybody agrees to it? Beta, carcinoma is after the toxic goiters. It will take another 1 day after tomorrow's session. Okay, perfect. Sounds like a plan. All right, okay, let's go. So when we talk about discrete thyroid swellings, the word discrete also means localized swelling. So until now, we were talking about a generalized swelling. Matlab, goiter is the entire or the generalized enlargement of the gland. Whereas now we are going to concentrate only on localized swelling, right? So localized thyroid swellings can be divided into two types. One, we can have solitary thyroid swelling. One, we have the solitary thyroid swelling. Another one we have called as the dominant thyroid swelling. Another one we have the dominant thyroid swelling. Now, normally, if one is solitary, the other one is multiple, right? So, rather than saying that, I'm saying solitary and a dominant thyroid swelling. Now, a solitary thyroid swelling or a solitary thyroid nodule will be a single isolated nodule that is going to develop from the thyroid gland. That is going to develop from a thyroid gland. Now, dominant thyroid swelling, the dominant thyroid swelling will have multiple small nodules, but one nodule will outsize the other. Get the difference. In a solitary thyroid nodule, there is only one single nodule which enlarges and becomes clinically relevant. Whereas a dominant thyroid swelling, you have multiple small nodules, but one nodule outsizes or outgrows the other, and this becomes clinically more evident. And such type of nodule are called as dominant thyroid nodules or dominant thyroid swellings. Approximately 70% of the localized swellings are solitary thyroid nodule. Only 30% of them presents with dominant thyroid swellings. Only 30% of them will present with dominant thyroid swelling. Now, when you see a patient of solitary, okay. When you see a patient of solitary thyroid nodule or a dominant thyroid nodule, I would like to represent it something like this. The patient would have a nodule which is present in the midline of the neck. Even in the patient who have a dominant thyroid swelling, because only one nodule is large, he'll also present like this only, right? So both of them is going to present with a single nodular swelling or a solitary nodular swelling. So looking at clinical scenario, it is very difficult to differentiate between a dominant and a solitary thyroid nodule. So what we do is we club both of them clinically and we call it as solitary thyroid nodule like presentation. We call them as solitary thyroid nodule like presentation. Beta incidence है 30%. 30% is the incidence. 70% of the patients who present with solitary thyroid nodule like presentation are actually solitary thyroid nodules, and 30% of them will have dominant thyroid nodules. And 30% of them will have dominant thyroid nodules. Okay. Now clinically they both are very difficult to differentiate, so we call them as one entity called as solitary thyroid nodule like presentation. Right. Now what are the conditions which can present to you as solitary thyroid nodule like presentation? One I have already discussed with you, that is thyroglossal cyst. Thyroglossal cyst presents to you as solitary thyroid nodule like presentation. Apart from that, the other ones are follicular adenoma. Other ones are the follicular adenoma, thyroid cyst, thyroid malignancy, thyroglossal cyst, follicular adenoma, thyroid cyst, thyroid malignancy, and thyroiditis. And thyroiditis. Even sometimes a isolated colloid nodule. These are the conditions. These are the conditions which are going to present as solitary thyroid nodule-like presentation. So these are the usual or the most common relevant conditions in thyroid which will present to you as solitary thyroid nodule-like presentation. Isolated colloid nodule. There means one nodule which is only filled with colloid, right? That is called as isolated colloid nodules. Now, earlier there was a huge issue कि किसमें क्या करेंगे, thyroidosis है तो what will you do, adenoma है तो what will you do, malignancy, thyroiditis. So there's a lot of hodgepodge that is going on. So the American Thyroid Association, that is called as ATA, in 2015 updated its guidelines. ATA 2015 guideline says, let it be any patient of any cause if the patient presents to you with solitary thyroid nodule like presentation. All these patients must and should undergo FNAC. So the criteria is, let's not get into the head, we'll give the headache to the pathologist. We'll tell them, okay, I have a patient with solitary thyroid nodule like presentation, go do an FNAC. Based upon the FNAC, we are going to interpret the results. Now, the following possibilities can occur. FNAC can turn out to be number one as non-diagnostic. FNAC can turn out to be non-diagnostic. Now, why FNAC turns out to be non-diagnostic sometimes is because majority of the times we don't ask them to take an ultrasound guided biopsy or ultrasound guided FNAC. So when the patient goes, the pathologist will try to feel for the nodule. Their hands are not as sensitive as a surgeon's hand because we constantly deal with the swellings, nodules, so we have a better perception. So sometimes they feel somewhere and they prick somewhere, and when they prick somewhere they get something else rather than getting the tissue from the nodules. Obviously it will become non-diagnostic. Okay. Now another possibility is that the report can come as absolutely benign condition. The report can come as absolutely benign condition, right? Another one, a new addition that is done by ATA 15, that is 2015, if the patient presents or the report come as AUS or also called as FLUS, FLUS. AUS means atypia of unknown origin. It means atypia of unknown origin. Atypia of unknown origin. FLUS stands for follicular lesion of unknown significance. Follicular lesion of unknown significance. Follicular lesion of unknown significance, that is called as FLUS. Another possibility that we can get from here is follicular neoplasia. Follicular neoplasia. If you remember the Bethesda classification, I told you the thyroid 3 category. The Thy 3 category is going to be guys, everybody is following. I get messages like the app is hanging, you're not able to follow. Good to go, guys. Good to go. Okay, fine. So follicular neoplasia is the Thy 3 category. That means where the pathologist is not able to tell me whether it is adenoma or carcinoma. I told you yesterday also the FNAC does not have the ability to differentiate between follicular adenoma and follicular carcinoma. Another possibility is I can have suspicious of malignancy. Suspicious of malignancy. And the last one is FNSE proven malignancy. FNSE proven malignancy. So based upon the FNSE, I can narrow it down to these following things. 1, it can be non-diagnostic. 2, it can be benign. 1, non-diagnostic. 2, it can be benign. 3, it can be atypia of unknown origin. Atypia of unknown origin, also called as follicular lesion of unknown significance. 4 stands for, or the fourth possibility that we have is follicular neoplasia. 5th, suspicious of malignancy. 6th is proven malignancy. 6th is proven malignancy. Now, depending upon these results, we'll decide our next move. If a patient who underwent an FNSE for solitary thyroid nodule-like presentation and the report comes as non-diagnostic, you will ask to repeat FNSE, but this time you are not going to take chance under USG guidance. So USG guided FNSE is the next logical step that we have for non-diagnostic aspirate. Now, if the report comes as benign, I will conclude or I will differentiate whether it is a cystic lesion or whether it is a solid lesion. If it is a cystic lesion, I would like to see or confirm whether it is a thyroglossal cyst or a simple cyst. Whether it is a thyroglossal cyst or a simple cyst. For thyroglossal cyst, I have already told you, we'll go for Sistrunx operation or Sistrunx surgery. For simple cyst, I would like to aspirate. Remember, you have to aspirate minimum 3 times. That means if it reoccurs more than 3 times, this is an indication for thyroidectomy. If it is a solid lesion, you can observe if it is asymptomatic. During the observation, if it increases in size or it causes pressure symptoms, the patient should be taken for thyroidectomy. Now, during the observation, you can also try suppression therapy. Questionable, but you can try suppression therapy. But I told you doubts last 15 minutes, right? So we're going to follow the same rule. So this is if it is a solid condition, right? Now, if you have atypia of unknown origin or follicular lesion of unknown significance, you are going to repeat FNSE. This time again USG guided. Sometimes when you have multiple nodules, your pathologist will have taken the biopsy from a non-significant nodule or the nodule which has less changes. So under the ultrasound guidance, you will see the nodule which have maximum changes and your pathologist will take the biopsy from right across there. Okay. Now that is if it is atypia of unknown origin or follicular lesion of unknown significance, repeat FNSE under USG guidance. If it is follicular neoplasia, you have to go for lobectomy, and under that, or see, this is one option that we have, or true cut biopsy. Both of them are accepted. Suspicious of malignancy. For suspicious of malignancy, you have to go for radioactive iodine scan. If radioactive iodine scan is inconclusive, then you have to go for either lobectomy or near total thyroidectomy, depending on the extent of the disease. Lobectomy, near total thyroidectomy or total thyroidectomy. All three are acceptable procedures. All three are acceptable procedures. Right? Okay. For proven malignancy, it is total thyroidectomy. For proven malignancies, it is total thyroidectomy. So this is the complete set of scenario if you have solitary thyroid nodule-like presentation. Beta, this is not Bethesda. Bethesda is FNSE classification for any thyroid nodules or any thyroid swellings. This is specifically for solitary thyroid nodule based upon what you get on FNSE, how to approach it. Okay. So this is a schematic representation. BX is biopsy beta. Good to go. Everybody understood this? Now you can put 2, 3, 4, 5 stars, how many stars you want. A lot of questions are framed from this protocol that I've laid down. So I've tried to simplify as much as possible. So this is the best simplified version that I could come up with. Alright guys, good to go. Beta, more than 3 means if it reoccurs more than 3 times. एक बार aspirate किया, फिर reoccur किया, फिर aspirate किया, फिर reoccur किया, फिर aspirate किया, फिर reoccur किया. 3 बार reoccur कर गया, चौथी बार if reoccur करेगा and you try to go and poke the patient again, he is going to hit you back. Patient का भी patience होता है यार. एक बार हो गया, 2 बार हो गया, 3 बार. बस after 3 times no. ठीक है. Good to go. But all radioactive iodines, now we give them as oral. So they have to drink. Usually we do it after 24 hours because the uptake is better after 24 hours. ठीक है. Beta, true cut के बाद depends on what you get. No, if true cut says malignancy, you'll go for total thyroidectomy. If you say benign lesion, you are going to go for lobectomy. बेटा ट्रीटमेंट इन AUS कुछ नहीं है, आपको FNSE रिपीट करना है. You'll repeat the FNSE again based on what you get the report. Whatever report is there, you'll act accordingly. ठीक है? Alright. Guys, you're not following the rules, then I'll also not play by rules. No, I told last 15-minute questions and now you're watching it. Now, so let's go for toxic swellings, right? So this is with respect to simple goitis. Now, the next topic I would like to talk about is toxic goiter. Toxic means hyperthyroid. Goiter is thyroid swelling, so hyperthyroid swellings. So our discussion will be taken down from the toxic goiter, that is hyperthyroid swellings. Now, hyperthyroid swellings or toxic goiters, I can divide them into 3 categories. One is called as the diffuse toxic goiter. One is called as the diffuse toxic goiter. Another one is toxic multinodular goiter. Toxic multinodular goiter. And the last one is toxic nodule. And we have toxic nodule. Okay. So diffuse toxic goiter, toxic multinodular goiter, toxic nodule, right? To understand, I can give example for each one of them. Diffuse toxic goiter, the example we're going to talk about is Graves' disease. For toxic multinodular goiter, I'm going to talk about Plummer's disease, and toxic adenoma is toxic adenoma, right? Now, so before we start talking about all these swellings, that is diffuse toxic goiter, toxic multinodular, and toxic nodules, the toxicity is because of two things. So the word when I say toxic, that means increase in hormone production, is because of two reasons. Either there is increase in hormone synthesis, either there is increase in hormone synthesis, or there is increased release of pre-formed hormone. Either there is increase in hormone synthesis, or there is increased release of pre-formed hormone. Increased release of pre-formed hormone. Now, when we say there is increased hormone synthesis, what are the conditions which are associated with increased hormone synthesis? Number one is Graves, which we are going to talk about. Number two is going to be Plummer's, that is nothing but toxic multinodular goiter, and toxic adenoma. All these three conditions are associated with increased synthesis. So which condition is associated with increased pre-release? Increased release of pre-formed hormone is usually seen in thyroiditis. It is seen in thyroiditis. But a toxic multinodular goiter is Plummer's disease. Side by side, okay. So this is very important to get the concept right. So when we talk about toxicity, the toxicity, basically the word toxic means increase in T3, T4 circulation. Now that increase in T3, T4 circulation can be because of either increase in hormone synthesis or increase in pre-release or pre-formed hormone. Okay. So all these three conditions that we are going to deal with or going to talk about is because of increased synthesis in hormone formation. It is because of increased synthesis in hormone formation. Okay. Now, okay, let's continue. Graves' disease is also referred to as primary thyrotoxicosis. Graves' disease is also referred to as primary thyrotoxicosis, whereas Plummer's disease is also referred to as secondary thyrotoxicosis. Graves' disease is also referred to as primary thyrotoxicosis, whereas Plummer's disease but a toxic adenoma is not a part of Plummer's. Toxic adenoma, toxic nodule का ही एक अलग नाम है, that is toxic adenoma. ठीक है. So don't worry, I will cover each and every aspect of the thyroid. Just be patient. ठीक है. I know I'm not entertaining enough, but I'm not here to entertain. We mean business, right? So entertainment के लिए बेटा कपिल शर्मा का शो है, बाकी nonsense तो बहुत चल रहा है. So you can go entertain yourself there. No? Here I mean business. ठीक है. So let's not fool each other. I'm not here to fool you, so don't eat my time as well. ठीक है. Now let's talk about primary thyrotoxicosis and secondary thyrotoxicosis. Now when I say primary thyrotoxicosis, what is the major difference when you call it as primary, when you call it as secondary? Take primary may the reason, the explanation is pretty simple. If you have symptoms of toxicosis first, followed by development of swelling, मतलब टॉक्सिक के सिम्टम्स पहले हैं, स्वेलिंग बाद में आया. ठीक है. तो सिम्टम्स फॉलोड बाय स्वेलिंग, सिम्टम्स पहले आए उसके बाद अगर स्वेलिंग बनता है, सच इज कॉल्ड एज प्राइमरी thyrotoxicosis. On the other hand, if a patient already have a pre-existing swelling which converted into toxic symptoms, which converted into toxic symptoms. This is referred to as secondary thyrotoxicosis. This is referred to as secondary thyrotoxicosis. Now, if you remember, I told you about multinodular goiter, and when we are talking about the complications of multinodular goiter, I told you secondary thyrotoxicosis occurs in 30% of the patients. Now, when I say secondary thyrotoxicosis, if you go back and recall, I told it's a pre-existing swelling which is converting into toxic state. Such is called as secondary thyrotoxicosis. Primary thyrotoxicosis is usually seen in young patients. It is usually seen in young patients, whereas secondary thyrotoxicosis is usually seen in elderly patients. It is usually seen in elderly patients. Now, few important differences that you would like to know about primary and secondary. With respect to symptoms or the system involved, the CNS system is more commonly involved in primary, whereas CVS system is more commonly involved in secondary thyrotoxicosis. CVS system is more commonly associated in secondary thyrotoxicosis. With respect to texture, the gland in the primary thyrotoxicosis is usually smooth and diffusely enlarged whereas the gland on the secondary thyrotoxicosis is nodular. It is nodular and it is unevenly enlarged Primary thyrotoxicosis usually have increased vascularity. Now, because it is associated with increased vascularity, the gland usually appears warm. Whereas secondary thyrotoxicosis is not associated with increased vascularity. It is not associated with increased vascularity, nor it is going to be warmer. So increased vascularity is warm because more amount of blood is responsible for calorigenesis, and calorigenesis is heat production, so you'll have heat interface, right? So increased vascularity is associated with warmth. Okay. With respect to hyperthyroid eye signs, remember, eye signs are usually found or are usually associated with primary thyrotoxicosis, whereas eye signs are rarely associated with secondary thyrotoxicosis. Right? So this is the root difference that you should set in your mind. Of all the differences that I've stated, the most important that you should emphasize is this one. Okay? So this is how you will know clinically, no beta, कि clinically कैसे पता चलेगा कि the swelling that you're looking at, is it a primary thyrotoxicosis or secondary, because both of them will present with toxic symptoms only, no? So in order to differentiate clinically, how do you become an intelligent clinician or an extraordinary and outstanding clinician? You ask the patient. History taking is an art and nobody can emphasize less on it. Okay? Now, if a patient has symptoms followed by swelling, it is always primary. If a patient has pre-existing swelling which converted into toxic symptoms or started developing toxic symptoms, it is secondary. Right? That is the most important. And then you see the age, which system is involved, they'll point. Remember one very important thing, whichever I've written here, this is usual. It does not mean that a patient of primary thyrotoxicosis will not have serious symptoms. It is nothing like that. They can have serious, but it is usually CNS which is more predominant. On the other hand, secondary thyrotoxicosis patients have CVS symptoms. That does not mean they will not have CNS. They will have CNS, but CVS is more predominant. Okay? So I hope everybody is clear on this page. बेटा initially why will you think toxic? Because patient will present with signs and symptoms of toxicity. No, अभी हम बात करेंगे. Patient will have swelling with signs and symptoms of hyperthyroidism, which I'm going to deal right now. Okay? So starting with Graves' disease. Just put your pen down, invest your mind on the screen, and let's see the flow. Okay, then I'll give you time to write. Now, with respect to Graves' disease, now Graves' disease is called as primary thyrotoxicosis. It is also called as diffuse hyperplastic goiter, that is toxic hyperplastic goiter. Also referred to diffuse hyperplastic or diffuse toxic goiter. All these remains the same. Okay. Beta, eye signs baat. See, every word that I say, I'll explain. Right? That's why I'm telling you, wait until the lecture to finish now, so you'll have a better understanding. I've planned it in a way that goes easy with you people. Okay. Now, with respect to Graves' disease, if you talk about an etiology, it is an autoimmune disorder. It is an autoimmune disorder and autoimmune condition. Now, we all know that the autoimmune conditions are more common in females, and that too younger female. So, Graves' disease is also seen in younger female. The usual age or the mean age of presentation is 3rd to 4th decade of life. It is 3rd to 4th decade of life. Okay. Now, when I say it is an autoimmune condition, the autoimmune condition will be associated with antibody formation. It will be associated with antibody formation. Now, the name of the antibody which are formed with respect to the Graves' disease goes by the name that is called as LATs. LATs stands for long-acting thyroid stimulating antibodies. LATs stands for long-acting thyroid stimulating antibody. Long-acting thyroid stimulating antibody. Right. Now, how does this antibody occurs? Before that, another very important thing, that Graves' disease is associated with HLA involvement. Mostly it is involved with two HLAs, that is HLA-B8 and HLA-DR3. A very important one which we usually ignore with respect to HLAs is CTLA-4. Another important marker is CTLA-4. CTLA-4 stands for cytotoxic T lymphocyte antigen 4. CTLA-4 is cytotoxic T lymphocyte antigen 4. It is also associated with marker CD40. Now, these are the 4 important markers that you need to remember with respect to Graves' disease. These 2 are very commonly referred, that is HLA-B8 and HLA-DR3. The new ones are important, that is CTLA-4 and CD40. CTLA-4 and CD40. Yeah, guys, take down this information. I'll talk about the pathogenesis in the next slide. So, Graves' disease is an autoimmune condition. All autoimmune conditions are usually seen in females which are younger, and the usual age of presentation is between 3rd to 4th decade of life. All autoimmune conditions are associated with antibody formation, and the antibodies goes by the name that is LATs, that is long-acting thyroid stimulating antibody. Now, these all are associated with HLAs. Now, when we talk about these antigens antibody complex, what will happen is the LATs which are formed. Now, let's say this is the follicle. Okay. And this is the TSH receptors which are present on the follicles. These are the TSH receptors which are present over the follicles. All these antibodies which are developed, these antibodies are by the name of LATs. Now, because the antibodies are synthesized and they are targeted towards the follicular surface, that is TSH receptors, they initially go and try to bind to the TSH receptor. Now, as soon as they go and try to bind to the TSH receptor, the configuration of the antibody do not matches the receptor, so they are rejected. So once they are rejected, here comes your HLA, that is usually your HLA-B8 and your DR3. They are going to help and cause or develop into a molecular mimicry. That means they change the configuration. Now, once the configuration of these antibodies are changed, they will start to configure themselves like the TSH hormone. Now, once they configure themselves, they will easily go and bind to the TSH receptor. Now, as they go and bind to the TSH receptor, they stimulate the follicles. Now, very important thing that you need to understand, that LATs, when they form, guys, good to go? Take it now. But I'll talk about all the antibodies, don't worry. Just concentrate on the one that I'm trying to address right now. Alright, good to go? Okay, so I'll repeat the pathophysiology. Again, see, it's an autoimmune disorder, so there will be an antibody formation. So these antibodies are named as LATs. So once the antibodies are synthesized, they are targeted against the TSH receptor. Now, once they target against the TSH receptors, this LATs antibody are going to go and bind to the TSH receptor. Now, the configuration of the receptor and the antibodies do not match initially. Now, because it does not match initially, it takes help from the body, that is human leukocytic antigen B8 and DR3. They help in molecular mimicry. Molecular mimicry is just to change the configuration. So the antibodies which are looking like this, they have transformed and changed their configuration so that this can suit and bind to the TSH receptor. Now, once they bind to the TSH receptor, they start to stimulate the follicles. Now, when they start to stimulate the follicles, the stimulation affects in two ways. One, within the follicles, it stimulates the follicular cells, which is also called as thyrocytes. Thyrocytes are nothing but cells which are present inside the follicle. Now, when the thyrocytes are stimulated, it will cause hyperplasia. So there will be increase in number of thyrocytes. It will increase in the number of thyrocytes. It will also cause increase in the size of thyrocytes. So there will be both hyperplasia as well as hypertrophy. There will be both hyperplasia as well as hypertrophy. बेटा antibody का configuration change होगा, receptor का नहीं, ठीक है? Now, because there is increase in number of thyrocytes and increase in size of the thyrocytes, it will cause increase in hormone production. Now, this increase in hormone production will result in toxic state. Will result in toxic state. Now, as earlier I told you that Graves' disease, the Plummer's disease and toxic adenoma is because of increase in hormone production. So this is how the hormone production is increased during the Graves' disease. This is how. Okay, I'll repeat again for those who are not able to follow. Everybody understood that the antibodies are formed, right? Those antibodies are against the TSH receptors, right? So they will try to go and bind to the TSH receptor. Initially, when the antibodies attempt to bind to the TSH receptors, the antibody and the receptor configuration doesn't match. So the human leukocytic antigens will, with the help of CD40, of course, there will be configuratory changes of your antibodies, and once the antibody configuration changes, this change of configuration of the antibody is called as molecular mimicry. Okay. Now this, after the mimicry has occurred, it will metamorphose. It will change its configuration so that it can go and bind to the receptor. Now once it is bound to the receptor, it will stimulate the thyrocytes. Once the thyrocytes are stimulated, there will be increase in the number of thyrocytes as well as size, which will increase the hormone production, hence the toxic state. Hence the toxic state. Right? So this is how the Graves' disease will cause toxic features. The clinical presentation of the Graves' disease will present with signs and symptoms of hyperthyroidism. Patient of Graves' disease will present with signs and symptoms of hyperthyroidism along with Graves' specific symptoms. Along with Graves' specific symptoms. Right? Now, what are the Graves' specific symptoms? Signs and symptoms of hyperthyroidism, I'll deal in a while. What do you mean by Graves' specific symptoms? In the Graves' specific symptoms, number one is Graves' ophthalmopathy. It is Graves' ophthalmopathy. Now, what happens in Graves' ophthalmopathy is, let's say this is the orbit. We all know orbit is a bony cavity. It is a very limited cavity. It has only 30 cc. Within that orbit, you have your eyeball, and within that eyeball, you have your ocular muscles also present, right? So you have the eyeball along with the ocular muscles in a small, tiny bit of orbit that is going to harbor your eye. Now, in Graves' ophthalmopathy, the antibodies which were developed, these antibodies sometimes they get misdirected and they go attack the ocular muscles. Now, as they go attack the ocular muscles, it will result in retroorbital edema because it is going to inflame the muscle, and inflammation will have edema. So, it is leaky endothelial capillaries will result in edema. So, it will be retroorbital edema. This retroorbital edema will push the eyeball outside. And when the eyeball pops out, it is commonly referred to as exophthalmos. Now, this exophthalmos in Graves' disease is called as Graves' ophthalmopathy. It is called as Graves' ophthalmopathy. Now, with respect to Graves' ophthalmopathy, which is the most common ocular muscle involved. The most common ocular muscle which is involved, let's say this is the eye. This happens to be superior rectus. This, let's say it's the inferior rectus. Let's say this is the medial rectus. This is the lateral rectus. Let's say this is the superior oblique and this is the inferior oblique muscle. It is the inferior oblique muscle. The most common ocular muscle to be infected. Anybody? What is the most common ocular muscle? It is inferior rectus. Second one is medial rectus. Third is superior oblique. And last or the fourth one is lateral rectus. So the order of involvement is inferior rectus, followed by medial rectus, followed by superior oblique, followed by lateral rectus. So this is the order of involvement. This is the order of involvement. Lateral rectus. These are the ocular muscles, no? Superior rectus, inferior rectus, medial rectus, lateral rectus, superior oblique and inferior oblique muscles, right? See, I'm so lucky that I'm teaching you guys, no? So the mnemonic is in the same context. The mnemonic that I can give you here is, I am so lucky, right? I stands for inferior rectus, M stands for medial rectus, SO stands for superior oblique, and L stands for lateral rectus. L stands for lateral rectus. Okay. So this is the involvement of the ocular muscles. This is our involvement. Yeah, beta. See, this retroorbital edema is the first cause, and later on, because of accumulation of glycosamine glycans, which is also responsible for Graves' dermopathy. But that glycosamines are more important for dermopathy when compared to ophthalmopathy, right? So I'm going to reserve that for that. All right. Now, Graves' specific, Graves' ophthalmopathy. Next is Graves' dermopathy. Next is Graves' dermopathy because of accumulation of glycosamine glycans. The most common site for Graves' dermopathy is anterior tibial skin. That is your shin. Another one happens to be thyroid acropathy. Thyroid acropathy is formation of new bones in the metacarpal. Formation of new bones in metacarpal. Formation of new bones in metacarpal. Another one is gynecomastia. So these are the Graves specific. These are the Graves specific symptoms, that is Graves ophthalmopathy, Graves dermopathy, thyroid acropathy, formation of new bones in the metacarpals, and gynecomastia. Right. Now, quickly talking about the signs and symptoms of hyperthyroidism. So, let's say this is hyperthyroidism. So, I'll be differentiating symptoms from sign. Right. Okay. Now, when you talk about symptoms and signs, before that, I want to know what is the basic function of the thyroid gland so that you'll be able to interpret it. When you talk about the function, number one, in children specifically, it is responsible for brain development. Number two, it is responsible for bone development and maturation. Number three, it is responsible for BMR maintenance. Number four, it is responsible for caloriogenesis. Number five, it is responsible for GI motility and glandular secretions. So it regulates the glandular secretions. Glycosamine glycans, Prabhu. GAG. Okay. Now, in hyperthyroidism, everything is going to increase, right? Hyper means more, so function will be more, right? Rather than brain development, it is about brain stimulation or neuron myelination. So, brain will be constantly triggered. And the brain is going to be constantly triggered, the patient is going to be irritable. The patient is going to be irritable, excitable, restless. So he'll be so restless and irritable that if you say कि तेरा hairstyle अच्छा नहीं है तो खींच के थप्पड़ मार देना उसने, ठीक है? So he's so irritated. So these guys are like, they pick up fights for small things. They're like, okay. I'll just finish signs and symptoms and then I'll wrap for the session. Okay. So it's irritable, excitable, restlessness. Now, because the brain is stimulated throughout the day, the patient is going to also have insomnia, which is going to land up to Sachin sir. No, so this patient is going to go to Sachin sir because he's going to have insomnia. Right. Now, as the BMR is going to increase, right? Bone. Not much. If it is in children, there will be, growth plates will fuse at the early location. Patient will have growth retardation. That's it, DOF and all. That's another discussion. With respect to BMR, the BMR is going to increase. Because the BMR is going to increase, the appetite of the patient is going to increase. Now, when the appetite is going to increase, we all expect that the weight should gain. But in fact, the patient either has a normal weight or patient will report weight loss. We all have that one friend, no, जो हमसे 10 times कम खाता, ज़्यादा खाता है, but never puts on weight. We eat a little bit and we put on weight. ठीक है? Right. Increase in calorie genesis, that means body में heat ज़्यादा बन रहा है, body has more amount of heat. If body has more amount of heat, will it be heat intolerant or cold intolerant? He'll be heat intolerant. He have enough amount of heat in the body, so he'll be heat intolerant. Increase in GI motility will result in diarrhea. Increase in glandular secretion, one of them are going to be your sweat glands. So sweat glands are going to be present, more amount of sweat will secrete, so there will be hot, moist pumps. Hot, moist pumps, right? So the symptoms are easily irritable, excitable, and restlessness. It is going to have insomnia, increase in appetite with either reported weight loss, heat intolerance, diarrhea, hot, moist pumps. Hot, moist pumps. Along with that, because the BMR is high, the body is under constant workup, patient will also feel tiredness. In fact, this is one of the primary complaints that you will say, we feel tired, feel karte hain, sir. Right? So these are the symptoms with respect to hyperthyroid state. Now in signs, everything will become fast, right? When we talk about fast, the patient is going to have tachycardia, that is increased heart rate. Patient is going to have hyperrefluxia. Patient is going to have hyperrefluxia. Patient will develop fine tremors. Patient is going to develop fine tremors. Patient is going to have specific eye signs, which I'll just cover in a while. Patient is going to have specific eye signs. Specifically, when you palpate the patient, patient is going to have audible bruit and palpable thrill. This is because of hypervascularity, which is seen exclusively or more common with Graves. As I told you, Graves is associated with increased vascularity. Increased vascularity, right? Of course, patient will also have a palpable thyroid gland. Palpable thyroid gland. Okay. So these are the signs and symptoms with respect to hyperthyroidism. Alright guys, okay, fine. Specifically in females, menstrual irregularities, that is associated with amenorrhea. Associated with amenorrhea. Okay, right. So as promised, I'm going to give you 10 to 15 minutes time to sort out your doubts. So those guys who are interested, they can ask doubts. I'm going to sit for 10 minutes. Rest of you can take a leave. We'll continue tomorrow. Right? Okay. So guys, if you have questions, start posting. Audible bruit. Yeah, BRUIT, correct. Beta era mechanism of Graves. Beta, you all need to decide on one thing, because the chat box is running like the birth rate of India, so can't really catch up what questions you are asking. बेटा ब्रूई इज दैट हिसिंग नॉइस नो, जब आप स्टेथ लगा के देखोगे, जब वैस्कुलरिटी इंक्रीज हो जाती है तो ब्लड फ्लो टर्बुलेंट हो जाता है ना, तो टर्बुलेंट फ्लो सुनने में मिलता है, दैट इज कॉल्ड एज ब्रूई. No, but Graves ophthalmopathy is one of the eye signs of toxic. When it is specific, when we talk about Graves, we talk about specifically of exophthalmos with pertaining to Graves. Guys, I'm not able to get any questions. I think this is not a good idea. Diagram of thyroid swelling. कौन सा बेटा? Last slide. Type. Beta, malignancy day after tomorrow. Tomorrow's will be toxic goiters and thyroid surgeries and clinical examination. And from day after tomorrow, we'll start thyroid malignancies. But a contrast CT is iodinated contrast. No, so whichever residual tissue is left out, that will take up the iodine that is given from the contrast. So the tissue will be loaded with iodine. Now, when you give radioactive iodine, the radioactive iodine does not have the space to go and bind to that particular tissue because it is already overloaded with iodine. Okay? Already it is iodine constipated, so you can't accommodate more. Hence, it will be ineffective. That is why we tell you not to give contrast CT before you do a radioactive iodine. If you're planning for radioactive iodine studies, you should avoid. In fact, it is contraindicated to do a contrast CT. But आई साइन कल डिस्कस करेंगे ना. But it's an autoimmune response. The body generates antibodies. No, LAX is from the body itself. Types of goiter. I think you mean this one. Okay guys, we'll start a thread in the Facebook only. This is not happening, not working also. Alright. बेटा टाइप ऑफ गोइटर दिखा तो दिया, और कौन सा गोइटर, कौन सा वाला? But I told you for all thyroglossal cyst complication, the surgery of choice is going to be cyst transfer. Let it be thyroglossal fistula as well. But eye signs I'll discuss tomorrow. We have run out of time today, no? बेटा कौन सा गोइटर वाला स्लाइड है यार? ये वाला. Okay guys, let's call it a day. It's not working out here. Yeah, we'll do this way. Post your questions on the Facebook group. We'll answer the queries then. Okay. All right. I'm good to go. I'll see you tomorrow guys at the same time. All right.